Right, good afternoon everybody. Thank you ever so much for attending this first face-to-face meeting of the Health and Wellbeing Board for a fairly long while. We're at Thursday the 29th of July 2021. Can I ask if we have any apologies for starters, please?
Yes, we have apologies from Councillor Williams, Steve Bateman, Gavin Boyle, David Cox, Ifti Majid, Andy Smith, Clive Stanbrook and Alison Wynne.
Okay, thank you. We're actually starting to fall into the holiday period, so one or two of those are away on holiday, but I'm sure they'll get the papers afterwards. I think there's a couple of new faces for me. Can I ask people to go around and introduce themselves, Steve?
Steve Studham, Chair Health Watch, Derby.
Thank you. I can do your microphone again, Steve, thank you.
Hi, good afternoon. Chris Clayton, Executive Lead of Joined Up Care Derbyshire.
Okay.
Hello, I'm Robin Jewis. I'm the Director of Public Health.
And
Moa Watkins, GP, representing Derby City at the CCG.
thank you.
Hi, I'm Jane Needham, Associate Director for Strategy at Derbyshire Community Health Services.
And Jane.
Hi, Gino Di Stefano, Director of Strategy at UHDB.
Gina, welcome, thank you.
Hi, I'm Danielle Lind. I'm Councillor for Blakeby's Ward and Children and Young People's Overview and Scrutiny Board Chair. Thank you.
Thank you.
Hello, I'm Emily Lonsdale, Councillor for Littleover Ward.
Thank you. And Angelique, welcome.
Angelique Foster, Police and Crime Commissioner for Derbyshire.
Your first Health and Wellbeing Board here in Derby, obviously. Welcome.
Hello.
Sorry, Alison, and then
Ladies first.
Alison.
Thanks, Roy. I'm Councillor Alison Martin. I'm Chair of the Adults and Health Scrutiny Board. Chair, if I may, I've just been ill and my ears are blocked. So, if people wouldn't mind, I couldn't hear some people. So, if they could speak into the mic, that would be very helpful for me. Thanks very much.
I'm sure they'll try. Thank you.
Councillor Roy Webb, Cabinet Member for Adults, Health and Housing.
I'm James Duffield, Community Development Officer for Derby City Council and Derby Homes.
Thank you.
Hi, I'm Dominic Monaghan, Democratic Services Officer. Thank you.
Lindsay Stevens, Democratic Services Officer.
So, all aboard, we are quorate and we can carry on with the business. So, the first, item 2 on the agenda is late items. I don't think we have any, Lindsay?
No late items.
Okay. Item 3 then is declarations of interest. Any declarations of interest, please? Councillor Webb.
Can I add a declaration that I am a member of the Joined Up Care Derbyshire Board now, and it will not be a pecuniary interest, it's just for the record.
So noted, thank you. Any other declarations? No? Okay. Well, item 4 then is the minutes of the meeting held on the 18th of March 2021, and I've got a note here on a couple of possibly outstanding actions. 2520, the COVID Outbreak Engagement Board and Health Protection Board update. It was agreed that the Chief Exec Derbyshire CCGs would liaise with the Director of Communications and Engagement CCGs to contact the Department for Public Health to progress the communication of information to the Health and Wellbeing Board, as statistics can help enforce the messages for hard-to-reach groups. Chris?
I think we've undertaken that, Chair. I'd obviously welcome any feedback if we're not seeing that come through.
I think we've got the statistics we need for today. But Lindsay, perhaps you could ask Alison just to reaffirm that we've got all those channels open. That would be good. The second one that looks maybe outstanding is 2820, really, the drink-free days Derby. we agreed that the Assistant Director of Public Health should draft a letter to be sent to the Chairman of the Chief Executive of Drinkaware regarding Drinkaware's lack of funding and resources for 2021. I understand that that hasn't yet been done, but Alison's picking that up and we'll follow that through and let us know. Is that okay, Lindsay? Okay. And so any other issues, actions or outstanding issues or corrections in the minutes from the 21st of March? No? Good. So moving on the agenda then to item 5, and that's the Joined Up Care Derbyshire update and developments from yourself, Chris, I think, and the Derbyshire Integrated Care System.
Thanks, Chair. Happy to take colleagues through. We've got the slide deck there, and if I could have the first slide, Dominic, I'd be grateful. It seems a long time since I've updated the Health and Wellbeing Board, so there will be some familiar slides here and some new ones. In fairness, a lot has changed since the last time I did a formal update. We've had, obviously, the Health and Care Bill is working its way through Parliament as we speak, and we've had what's called the design framework from the NHS on the role of integrated care systems. So I've pulled these both into the slides, which I'll take you through. So the first slide just reminds colleagues what Joined Up Care Derbyshire is, and of course it's the Health and Social Care Partnership for Derby and Derbyshire, and it's for all ages. It's here, as colleagues know, to improve health outcomes for our populations that we serve, and obviously that fits very well with the health and wellbeing strategies of city and county in the slightly different terminology, but above all helping people have the best start in life, live well, age well and die well. And if I could have the next slide, please, Dominic, and then the next one, please. In terms of the priorities, they're recognisable. I'm sure colleagues won't dissent from these, but they are essentially helping us to come together and do that priority that I've just set out. I'll not take you through them because you have seen these before. There are a couple of slides on there I will stay on for a while, so if we could move forward. In terms of integrated care systems, again, you've seen this before. The purpose of them is really now defined on that bottom 4 bullet points there in terms of the key purposes of a integrated care system. So improving population health, tackling inequalities, enhancing productivity and the effectiveness of our services, and clearly supporting that broader social and economic development. So what's new, if I could have the next slide. So what's new since I last spoke to the board? Well, we've got the Health and Care Bill. Well, what does that do? Well, it sets out 3 important statutory bodies or groupings. The terminology just does change. The last one, which is clearly Health and Wellbeing Board, hasn't changed very much in terms, but it is mentioned, and that's why I've put it there. But there are 3 groupings that we've started to talk about. The first one is something called the Integrated Care Board or Body, and that will be the new NHS organisation that brings the sort of collective effort of the NHS together. As you know, the NHS is built up of a family of lots of different organisations, and the Integrated Care Board will help bring those together. The Integrated Care Partnership. Now, that is the partnership between that NHS body that I've just mentioned and our local authorities, particularly the local authorities with responsibility for social care and public health. So in other terminology, it'd be the upper tier local authorities. And together, the NHS and local authorities create this integrated care partnership, and it is that is the integrated care system. There's some definitions there in terms of the Integrated Care Board, in terms of how it's to be constituted, and I'll bring further guidance on that in due course. But hopefully those principles of those different groups is helpful. And if I could have the next slide, Dominic, I'd be grateful. So I suppose what's new, what didn't we know before? Well, actually, we knew quite a bit of this in terms of the conversations we've been having over the last 12 months or so. But there are some things that are sort of reaffirmed, really. So the purpose of the Integrated Care Partnership, the link between the NHS and local authorities around social care and public health, that will have a purpose set out in statute to create an integrated care strategy. And interestingly for this board, to implement a joint local health and wellbeing strategy. So that would fit very well with responding to the Health and Wellbeing Board's objectives. There's some strange terminology, but bills are obviously challenging to read for laymen in legislature. But it's important that the Integrated Care Partnership creates this strategy in an open and transparent way, and it advertises that and sends out copies to relevant organisations and takes the views of the constituents of those areas and obviously the local organisations, including the Health and Wellbeing Board. The NHS element is set to create a 5-year plan annually, to review it annually, setting out how it will respond to the integrated care strategy and the health and wellbeing strategy, so that there's some real clear lines forming there. But it reaffirms the role of the Health and Wellbeing Board in some of the service reconfiguration work that we've brought previously. Probably more of interest to me on the NHS side than to the Health and Wellbeing Board, but it's very clear that there will be a direct relationship between the new Integrated Care Board of the NHS and NHS England, which will become the new body for the NHS covering England after the merger of what is now known as NHS England and Improvement. And if I could have the next slide, Dominic, thank you. Big slide, this one. I'll just pick out some salient points. Again, I don't think this will be a surprise to the board, but what it will mean in technical terms is the clinical commissioning groups will cease to exist on the 31st of March next year, and the functions of clinical commissioning groups will move into the new NHS body. I think the formation of the Integrated Care Partnership will be a really excellent opportunity for us to move on from where we've got so far and improve the collaborative working that we've already established, so a really positive thing. And it reaffirms the need for the NHS, on one hand, to integrate more with itself in terms of collaborating within the NHS around certain areas like hospital services, mental health and ambulance care. But it also reaffirms the need to integrate across both the NHS, public health and social care, which I think would be helpful. I think setting out in statute that the NHS and the Integrated Care Partnerships have an interest in the wider determinants of health is also helpful, because of course they don't have a direct influence over many of those, but they certainly have an interest in them, and I think that again is helpful. And if I could have the next slide, please, Dominic. This slide will be very familiar to everybody. We use it a lot to set out the determinants of outcomes for health of our population, and we'll all be familiar with the different columns that there are there that contribute to the overall health of the population. And as you can see in the purple section, the contribution of direct clinical care, approximately 20%, and the wider determinants are clearly set out there. But interestingly, when I now look at this with a lens of creating the integrated care system, from my calculation, I think we've got 50% of the statutory interest in the determinants of health within the Integrated Care Partnership. If you bring the NHS, social care and public health together in that partnership, if you've got the health behaviours, which are certainly in the influence of our local authority and public health department, and the clinical care elements, bring those together, you can see by simply bringing that partnership together, your influence has increased. But that's not all of the contributors of health outcomes, and you can see some of those socioeconomic factors and some of the environmental factors don't fall directly in the influence of the health and care partnership. So, got a couple of cheeky slides that I'm just going to take you through now, just to test some thoughts with Health and Wellbeing Board about how do we tackle the 100% of those outcomes. And in front of you is a slide I've just put together. It's just a thought slide. I've looked at this in great detail. You'll be pleased to hear. And when I've looked at it, the only board or group or statutory influences that oversee, I think, the 100% of those outcome areas that are on that slide. When I've looked at statutes, the only group I can think of that has that influence and reach over all of those is the Health and Wellbeing Boards, in my humble opinion. And so I've started to think about, well, if Joined Up Care Derbyshire could contribute the NHS, public health, social care element into a Health and Wellbeing Board conversation in a more unified, singular, coherent way, then that might allow the Health and Wellbeing Boards to stretch their wings a little bit and contribute more thought into some of those other areas as well around the built environment and some of those socioeconomic factors. So this is just a sort of concept I'm just testing at the moment, that if we streamline some of our action on the health and care side of the street, would that help the Health and Wellbeing Boards stand back further and not get bogged down in some of the things that we've brought previously and be able to take that broader view? But it's a question. And if I could just have the next slide, Dominic, thank you. So what this is and what it isn't, the work of Project Derbyshire will never stop. It will always evolve. And so this, where we've got to at the moment will never be a final state. It will always change. And I think we all accept that we're heading into a new statutory arrangement, but the project of improving outcomes for the population will always continue. But it is a helpful step because it builds our clarity and our ownership and starts to help us think about how we could tackle some of these challenging things going forward. What we've got at the moment is a real mixture of things that we've worked on for a few years and are ready to go, and some things that need a bit more work. And everything that we've been doing so far has been built on the functions of the integrated care system and the broader partnerships that we have. And we've tended to come away from what this means for individual organisations. So you haven't seen me in these presentations overly talk about the role of the CCGs, for example. We've talked about what are the functions we need in a system. It remains very complex and complicated. That's true of most things, but it remains so. Improving outcomes and improving life expectancy for the population is not easy. And then the next slide, I wouldn't overly strain your eyes on it, but we're working on a concept with NHS Public Health and Care colleagues about how does the integrated care system start to really get ahead of its strategic ambition? How does it really start to look forward and set out what are the key things we should be doing to improve population health? And this slide is just an illustrative of where that thinking has got in terms of creating a strategic intent function for the integrated care system, and what the role of that might be in helping both respond to and support the creation of health and wellbeing board strategies in the future. But all it shows is the complexity and all the different partnerships you need to think about, all the different groups, all the different components like prevention and clinical strategy and outcomes that we need to think about and work through, which has been a challenge to date. And I'm nearly there, Chair, you'll be glad to know. And if I could just have the next slide, please, Dominic. So what I've sort of set out is what's the latest update on the statute, put out some thoughts really on if the integrated care partnership forms in this way between the NHS, social care and public health, what could that mean for the work of the Health and Wellbeing Board? And today's the start of a conversation, not the end of one. And we'll start to think about it. We're obviously in July now, but during the course of July, August, September, we'll give that much more thought and come back in due course. And I'll stop there. The slides, there's loads of appendices, slides with lots of detail for colleagues who want that, but I'll stop there. Take any questions, Chair. Thank you.
Thank you very much, Chris. There's quite a lot on there, obviously. Got a lot of things to think about there. Questions, comments, for starters? Yes, Councillor Webb.
Comment rather than questions. It's nice now that local authorities have been invited to join the setting up of the integrated care strategy and partnerships. Health are recognising the input that local authorities can make, particularly to the wider determinants of health. We've got public health and social care linked in with the integrated care system, but the wider determinants, so alcohol, obesity, healthy living, social and economic factors, particularly housing, I think that is something where the integrated care system cannot deal with, but can add value to by particularly picking up patients where housing in particular is a serious issue for them, whether that be the accommodation or the suitability or factors in the accommodation that put them at risk. So I see the Health and Wellbeing Board actually delivering on questions like that, socio-economic questions, rather than the health side, which the integrated care system will deal with. And it's been a pleasure to partake in some of those discussions.
And I think that's been a good start, hasn't it? It's talking about, depending on the view, continuing the strategic discussions between the partners and some of the new partners to the table, sort of in effect. Are we convinced, Chris, that we've got buy-in from all the new partners and all partner agencies into what we're looking to do?
I think so. I think the biggest challenge is coordinating our effort. I think there's lots going on, and historically there's always been lots going on, but it's about bringing it together and making it more powerful. I think Roy's right. The Health and Wellbeing Board could have a massive role in pulling this together and helping us see further than health and social care. And I think Roy's onto something there about thinking about the reach it could have. It's not easy to reach into some of the socio-economic conversations, but I think the Health and Wellbeing Board could bring some of those together and certainly ask the right questions of them. So I think Roy's right. But so far so good.
But to tackle some of those initiatives, different authorities, local authorities in different places in relation to what their ability and resources to be able to challenge them and to do those and to provide those services. So any strategies is more effective the wider it reaches, of course. So there's some challenges there for me as well. Pervez, you want to come in?
Yeah, thank you, Chris. Just a comment from me, really, that all the organisations that we're bringing together in a partnership or exist already, and not so much as a cohesive whole as what this is attempting to do, but I do think that what we need is a relentless focus on what it is that we want to do, particularly with regard to health inequalities, because it's such a longitudinal goal that it's easy to lose amidst all the operational pressures and issues that we face as a health and care community, as a population. Actually, that's easy to lose that and put it on the back burner, and because it's been there, hasn't it? It's been there for the last decade. We've known about it. We've got the same actors in that play, and if we don't have a relentless focus, we're going to have the same ending for that play. There's no reason why it will be different. We've just got to have much more of a focus and be extremely zealous in terms of pursuing that if we're going to make a difference.
Absolutely, and that's going to be down to these strategic discussions and between the agencies. And actually, item 10, I think that Robin, you're going to be presenting, talks about how
really sorry to interrupt, Chris, but I know I'm in some exceptional state here of a blocked ear, but I really can't hear you at all, so I can hear the others. So would you mind just speaking up a little bit, please?
I'll get as close as I can, Alison. Is that a bit better?
Thank you, Chris. Sorry
I'm such
about
a softly gentle spoken
Hopefully
person.
I'll be back into normal. I'll be less cronky soon, but thank you very much.
Okay, no problem. So I was about to say that in item 10 we talk about how the Health and Wellbeing Board itself can look at this, and you'll expand on that later, Robin, yeah, in terms of the next Health and Wellbeing Board and how that will look at and review the role and function of the Health and Wellbeing Board in all this. So yes, moments.
Yeah, I just wanted to expand, I suppose, on sort of what Roy and Pervez have said. I've been coming to these meetings for, I don't know, a couple of years or so, and we seem to get a lot of information, we talk about a lot of information, but I don't know how much we kind of demand of each of the organisations. So Roy and I were talking in a sort of pre-meet about the housing, so there's a lot of fantastic work that's been done on the housing, and great work, but actually as GPs, as paramedics, as the police, as the fire service, we're the sort of eyes and ears on the ground. But if I go and see a patient who lives in difficult circumstances, I kind of feel a bit helpless. I'll sort out their bronchitis, I'll sort out their... But there's very little as a GP I can do about their damp. And actually, I think, although that's sort of going down to the minutiae, I think we should be expecting the organisations to come up with plans of what are you going to do if you come across inadequate housing? What are you going to do if you come across overcrowding? Because actually that then affects things like the COVID and just that, rather than reacting to reports, actually being proactive and saying, this is what we expect of you. What are we going to do about smoking? Because actually there are lots of people who see people who smoke who aren't actually health professionals, aren't smoking advisors, but they're in contact. So it could be the housing advisor speaks to them. So it's just, we've got a fantastic group of people in this room, but I'm not sure we expect and demand of them. I don't know, that's a bit presumptive. But it's a unique group with all the different people of the integrated sort of care system in one room, and it's a real opportunity, and great work gets done, but I think we acknowledge it rather than demand the other way. But it is a great group.
You make a couple of very valid points, and the first one for me is you as a GP and your surgeries should know that there should be a system for you to know who to go to and how to get the damp issued and issues sorted.
The problem with that is I've got, I work 13, 14 hour a day. I actually haven't got time to spend half an hour to find out who I contact about the housing. It needs to be a concerted effort that in my organisation, perhaps coming from Chris, this is the number you ring, 2-minute phone call and it's done. And that might be that there is that case and there is that number, but actually it's not disseminated. So
those contacts and links should be available to you, at least your practice manager, to be able to do those.
It's not happening on the ground.
Well, we need to try and address that. The other crux of the matter for me, the word you used was demand, and expect and demand, and that's a difficult one because we don't have those statutory powers, do we, to call on demand of people or to enforce some of what we recommend is done and what we all sign up to, whether the powers to demand or enforce what it is we've said we're going to do.
If as a group, though, we come to a decision that we're going to concentrate, say, on smoking, I think as a collective group we can expect each other to go back to our organisations and then put things in place. We can't demand that individuals do things, but we can come to a collective decision and then expect that to happen. Whether the individual on the ground do it is another matter, but if we talk about it but don't actually put stakes in the ground, we're all really busy and it never quite gets done, or it gets done ad hoc.
But I guess the integrated care system should be designed for everybody to know and understand what those priorities are and to understand their role in delivering it, I guess. Alison, you wanted to come in?
Yes, thank you, Chris. I appreciate I'm new to this board. Some of you will know that I've been previously a councillor before, though, and so I very much agree with the kind of sentiment that you're saying. I'm sure most of us feel that, we often sit around and there's a lot of talk, and as Perez says, we need concerted, sustained, systematic and pushing action. But the only, and so I think that is right. I think, though, that on some of the things you talked about, there isn't a demand button. I mean, maybe you should have those numbers available to you. I think that's right. But I think most elected representatives in this room, and I can't speak for all parties, but I think all parties know that when they are faced with someone who contacts them and they've got damp or there's overcrowding, they do everything they can, but there isn't a demand answer, there isn't an immediate solution. I've been recently engaged with a family of 7 living in a 2-bedroom flat, 6 feet up in a tower block. Derby's only one that recently had a fire. And I don't believe it's the role of councillors should determine who lives where. I think that's wrong. But nevertheless, it's so bad, this scenario. I have talked to the chair of Derby Homes, and they simply do not have anywhere to move this family to. So it's not always that there isn't a will and there isn't a push. It's just that the resources and the facilities aren't there to resolve them very quickly, unfortunately.
It seems though I kicked off some of this stuff. I feel honour bound to help out. And I think you're right. I think item 10 will help explore this. But it's probably a language issue in the use of words. So whether we demand or request or ask, I think and I think the Health and Wellbeing Board certainly could have a role in asking the contributors to health outcomes across those wider determinants and the health and care determinants, what they're doing to support the delivery of the Health and Wellbeing Board strategy. I think that's in statute and would not be unreasonable, and I think a concerted effort and continued asking will do quite a lot, actually. So I think Meryl's sentiment, is correct. We just need to find the right balance and the right words, I think the Health and Wellbeing Board could ask a lot more if it was minded to. But thank you. Thanks for the comments.
I did, yes, Chair, because we've been discussing through Joined Up Care Derbyshire about lessons learnt from the pandemic, and one of the things that's been a great success has been the hub in Derby, where there is a single point of contact for everybody with a problem. And Merrill isn't the first GP that I've spoken to about how GPs can actually contribute and make a difference to the standards of housing in particular that their patients are living in. And we're looking at the model that was developed by the hub so that we can produce a similar one for health across the city and across the county, where a one-stop shop is available similar to the hub. So a single number where GPs or anybody can go with a problem, and it's then registered and sent to the relevant people to deal with, rather than an individual having to go through the maze of what is local government and NHS. So we are looking at solutions.
Excellent. Chris, I'm conscious of March next year is when the changeover comes, if you like. And that sounds a long way away, but it's not actually, is it? And what are the challenges? Have we got a plan, a strategic plan for how we get to that point?
Yeah, I have to be honest, and I would say this, wouldn't I? I think we're really well placed. I'm quite assured that we'll do the necessary statutory changes that will be required to get us to the 1st of April. So on the NHS side, reform is not a new thing. It happens every so often, usually somewhere between 5 and 10 years, that there is a change. So it's something we're quite used to doing and somewhat expert in. So I feel quite assured on the NHS side we will do the necessary safe and legal changes to close one organisation and create another. I think, I have to be honest, I think Joined Up Care Derbyshire is in a very good place between the partnership of the NHS, social care, public health on behalf of the local authorities. I think it's in a good place, and I think it wouldn't be a huge leap to formally create the integrated care partnership from where we are. There's a lot of conversation to be had about the finer detail and, you know, who's on the ultimate board that runs that, of course. But I've no significant concerns that we won't get there. The project, continuing project Derby and Derbyshire of improving outcomes will continue. You know, it's happening today and it'll continue after April. And all the work we've just been talking about now around health and care determinants, wider determinants, will carry on. And I'm going to keep in mind Pervez's comment there about that consistent, coordinated, ruthless focus on it, and that's what we'll need to take through the legal changes and not be distracted by them. So yeah, I feel quite confident, but you are right, it will be here before we know it.
And Pervez, we're equally confident from a local authority point of view that we can do this. Yeah.
Yes, absolutely, Chris. I mean, Health are the lead organisation, and I take confidence from Chris's confidence.
Good. Okay. Well, I'm conscious of trying to keep to the agenda, timescales and things. So, thank you for that, Chris. It certainly helped focus my mind on some of this, and we'll take it forward from there. So, moving on. Item 6 is the Outbreak Engagement Board. Robin, an update on where we're at with things?
Thank you. So there is a very brief paper in the pack just summarising our current arrangements. If you remember, we have Outbreak Engagement Board, that's a subgroup of this board that meets regularly to review the local situation in relation to COVID. We also have a Health Protection Board which has met since 2013, or actually before 2013, and reports to the board. That our usual, if you like, Health Protection Board hasn't met since last summer, and we're in the process of arranging another meeting coming up in the autumn. But in the meantime, our COVID Health Protection Board continues to meet. And so what I've got for you today is just a really brief update on where we currently are with COVID in the city, and very happy to have any questions. So next slide, please. Thank you. So this is the chart from our latest report, which is published on the website. And what you can see on that is the orange bars, which are the Pillar 2 or community-based testing results, and the blue bars, which are the Pillar 1, generally hospital-based testing. And you can see on that chart very little data from March and April last year when we had very limited testing. And then you can see the start of the wave in the autumn last year, the impact of the lockdown in November, and then the recurrence of the wave over with the peak just in early January after Christmas. And you'll see that we were progressing well from that, and then following on from the relaxation of the measures with the increase in the vaccination uptake, you can see the anticipated increase in numbers of cases that we have there on the chart. So on our latest data, which is up to the 24th of July, we had 772 cases in those 7 days, which is a rate of 300 per 100,000. So we've very much followed a national picture on this, both with the increase and then a slight decrease in the number of cases in the latest week. And you'll see that the national rate is 377 per 100,000. So we're below that, but not far off the national rate. And I think there's considerable speculation as to what this reduction in cases may be all about. We know that the change in COVID is influenced by our activity, and what we do know has happened over the past month is that we had the Euros, and we know that there was a huge amount of mixing, particularly in social settings, associated with the Euros, and we also had considerable cases occurring in and around schools as well up until the end of term. It's important to note that sometimes we see transmission between children in schools. Sometimes schools are effectively there's a phrase for it, the nightingale. I'm not sure that's the right bird. The canary in the mine, who are detecting what's happening within the community earlier than we see elsewhere, and I think we've seen that over time as well. So we had that increase in cases, we've had a decrease. At the same time, we're aware that schools have come to an end, and we've also noticed that there's been a drop in testing as well within the community. So I think there's questions around, are we testing fewer people and finding fewer cases? Has this been influenced by a reduction in contacts because of the end of the Euros and the closure of schools? But what we do know is there's still considerable amounts of COVID around in the community, and we know that the majority of the cases are Delta variant, and that is incredibly transmissible. So we do anticipate that as people continue to mix, and following on from the relaxation last week, we do anticipate that those numbers are going to increase. Whether we have a stabilising of cases over the summer in relation to seasonality, as we saw last August or not, is difficult to know. But we do know as we come back together again in September, schools are back in, people start to move around a lot more. We saw it last year. There's every reason to anticipate we'll see an increase in cases in September again as well. So next slide, please. So this is just indicating what's happening within two key age groups. One's the 17 to 21-year-olds, and the other is the 60-plus-year-olds. So you'll see with the 17 to 21-year-olds, and although we've got that particular age group, this is reflected across young people generally, certainly in the under 25s, under 30s. We saw that there was a very large increase in cases, which pretty much mirrored the number of cases in that age group in January at the last peak. And what we saw in the over 60s was a small increase in cases, and this will definitely have been influenced by the vaccination. We know we have very good vaccination coverage in the over 60s, and so they are less vulnerable to infection, although you'll see that people within those age groups have still been infected. And we are seeing a corresponding increase in the activity within hospitals. Sometimes this is related to accident and emergency attendances as well as hospital admissions, but nothing compared to what we saw previously, which is the positive impact of the vaccination in that age group. And the next slide, please. So across Derby and Derbyshire, 1.4 million vaccinations delivered, which is, when you take a breath, that's an absolutely astounding number. And 7,000 delivered across that area between the 23rd and the 26th of July. We've got very good uptake of the first and the second doses in the over 40s, and it's under those age groups, the people who've become more recently eligible for vaccination, and perhaps the people who may feel they're less at risk from COVID, that we are continuing to work to increase the coverage and the uptake for. And particularly, we're looking at targeting vaccination programme with the under 30s and particularly those sort of 18 to 24-year-olds. And also not forgetting, we also have groups within our COVID at-risk group, which is those people who are on their GP registers for their chronic conditions, who are very vulnerable to COVID infection. And we still have some work to do around encouraging those individuals to come forward. Next slide, please. So as far as the guidance and our actions are concerned, the legal stance of those actions changed, but the guidance still remains, and you'll note that our promotion across the city has remained exactly the same, in that those actions we were previously doing, covering our faces, washing our hands, keeping our distance from others, making sure that we meet outdoors where we can, all still very pertinent in controlling the spread of the virus. There's plenty of virus still there that's spreading within the community. There's been a great deal of discussion this week around the changes in self-isolation for certain key groups, but from Monday the 16th of August, the plan is that all people who have been vaccinated will be eligible to be released by a negative PCR test from that isolation. And we're just really considering and working through what the implications of that will be, because we do know that that people who are contacts are becoming cases, and so there is a risk involved in that change. And importantly, at the moment, unless somebody is classed as exempt from isolation, they are still required to isolate if they're told to do so by the track and trace programme. Thank you. So the key messages from that really, it's positive that we have shown a reduction in cases in the city. It's positive that hospitalisations are reduced, but we need to be really cautious because COVID hasn't gone away, and the relaxation that happened last week is likely to lead to an increase in cases, whether that's reduced by seasonality and the schools being closed over the summer. It will definitely come in September. So absolutely vital that we continue to follow the guidance, but also that we continue to promote vaccination and to make that as available and as accessible as possible. Thank you. So very happy to have any questions.
Thank you, Robin. We may be battling against the tide of people relaxing on these COVID things, as we talked about earlier on, and every time I speak to you about it, I remind you of the position when we were worried about going over 20 cases per 100,000. So I think we're slightly above that at 300, aren't we, at the moment. Comments, questions? Yes.
Thank you, Chair. I just wondered, are there any plans to encourage further testing across the city, like setting up any further testing stations, etc.? Thank you.
So we continue to promote the testing. We don't have any current plans for the mobile testing. I think is that specific. We don't have any current plans for that at the moment. We did have a mobile testing unit in Little Over School a few weeks ago, and that was specifically focused because we were seeing a lot of transmission in the local area. I think the challenge that we now have is that at that time we could focus within a particular community, particular setting and particular group. The challenge we now have is that when we look at the information and the data that we have on the cases, it would be really hard to pick a target group out. It's very distributed across the city, across different age groups as well. Even though most of the cases we see in younger people, it is actually distributed across all age groups and across all ethnicities and all deprivation groups as well. So if we were to see a particular group that we could really focus on, we always have that option in mind. But there isn't any indicator for us for that at the moment. So it remains that continued message around testing. And also I think there's been a little bit of confusion between the lateral flow tests and the PCR tests and when to use them. We've been doing some particular focus on that and just reinforcing that lateral flow tests are for regular testing when you don't have symptoms, and that the PCR testing is absolutely for when you have symptoms or if you have a positive lateral flow test. So yes, I'm not sure if that is a long answer, apologies, but I hope that covers your question.
That's okay, thank you. Is there any more we can do, Chair, as a council to try and get that message across about testing and communications?
We're doing it on a regular basis, actually, at the outcome, at the Outbreak Board and the other board. And our communications team are on it and repeatedly pushing the message out. So I think the short answer is no. I think we're doing as much as we can. But we're battling against the tide of change in effect, and this expression of, we're going to have to learn to live with COVID, because is a worrying one for me. But it does beg for me the question where we're going with, it begs the question for me where we're going in terms of the next steps, and so booster vaccinations. There was a lot of discussion around whether boosters could be delivered alongside the flu, this year's flu. And I understand there's some concern about a potentially quite high flu rate this winter if we follow the Australian model. So is there any update on that, the thinking in relation to whether we can do both at the same time?
Yeah, happy to. So this is phase 3 of the vaccination programme. We're coming to the end, but it will never be the end of phase 2, because we'll always continue to offer vaccination to those eligible members of the public who haven't had it done yet. And I think the key message for me from Robin's description is anything all of us can do with any under 30s that we know have not yet taken up vaccine, it would be to encourage, because the evidence is really strong. And amongst the changing position, it's one of the things that we can continue to promote, and we can clearly see the benefits of it. So that'd be my first plug. In terms of phase 3, yes, there are two things to consider there. The firstly is the third vaccine, or booster vaccine as it's been called, that we'll be starting to work through from September onwards. And we're currently finalising our plans on how to do that, because obviously the vaccination programme is a significant programme. It's clear from the government's guidance and the JCVI's guidance who will get those, and it's set out in terms of the at-risk groups particularly. But you're absolutely right, Chair, to pull out the flu season this time. And one of the concerns of the health and care system is the re-emergence of other viruses that, because of lockdown and the changes in public behaviour that we've had during COVID, we've not seen the scale of those other viruses that we've had before. Flu is one of them, but there are other respiratory viruses and gastrointestinal viruses, diarrhea and vomiting viruses that can spread. And so one of the concerns of the Health and Care Service is the emergence of those in the autumn, starting at the end of summer, that we're having to make plans for. So you're right. But the flu vaccination programme, as you know, very, very successful campaign done every year. We're increasing its reach this time, so more people are eligible to have that, and so we're rolling out that programme. We're looking at still the ability to vaccinate with both vaccines at the same time, and the current thinking is that we'll probably target that on health and care workers in terms of the rollout to do that, but we're still waiting that final guidance on how that can be done. But you're absolutely right, there'll be two big programmes going on, flu and COVID revaccination in that autumn and winter period. More detail to come.
Okay, yes.
Just a couple of things. With the flu and COVID update, certainly all the practices in Derby City are geared up to go. It's just the practicalities. We've already got our dates for when we're going to be doing them, and very much like the flu season, we do that months and months in advance. So everything is ready to go. I think there's a couple of things. I think in general practice, we're seeing an increase in consultations by phone about COVID symptoms, which doesn't really sort of relate to your figures. So a lot of patients diagnose no COVID to us with COVID symptoms. So they ring up and they say, I've got a cough, temperature, loss of temperature, but I don't have COVID, because they don't want the implications, particularly now because they're going on holiday. So they don't want to have that diagnosis. And the other thing, which is not just general practice, it's affecting the council. It's this track and trace. It's really helpful that we've got this sort of get out of jail card, but on the ground it's not particularly helpful. We've got one of our GPs off because their daughter's got COVID. None of us want her in the building, and we certainly don't want her seeing patients, however fit and healthy. I don't think any young 20-year-old would want to see a GP who might be harbouring COVID. So in reality, it's not helpful. And I mean, our practices, we've just got one member of staff off working from home. Other practices are having much more of a difficult time. And I know it's affecting the refuse service and everything, isn't it, in the council. But I think that is the biggest area of concern in general practice in the city and wider. It's that lack of staff. We only need 2 or 3 clinicians to go off, and then suddenly we haven't got anybody seeing face-to-face patients.
Okay, yes.
Just to echo a couple of those points, really. From a hospital perspective, I think very encouraging to see those figures, but equally, I mean, I think the point well made that the management of our pathways and all of our protocols, you know, they're still in place, and they impact heavily on the amount of patients we can see and how productive we are. But the workforce impact is still significant, whether that be through illness or including mental health. You know, there's still a lot to be said about the impact the pandemic's had on the wider workforce across all partners, which is still being felt and indeed managed. But equally, the point Chris made about the uncertainty of winter, like never before, we look ahead and it's really difficult to plan. And the point about focus, you know, engaging our frontline teams on this much wider, really important strategic conversation about our role in, you know, population health in the broadest sense, at a time when, you know, a lot of our operational teams, our clinical colleagues are running to stand still. I think it's just something that I just want to get over. But the will to both not just get through winter and beyond, but to really engage in this conversation about what does this mean for my role, I think is really there to see. So encouraging signs, still a lot of operational and practical difficulties, as well as a workforce resilience thing to consider. But I think it's only together, you know, in our collective energy and willpower will we see this through. But at least we can start to see, hopefully, a light at the end of the tunnel.
Thank you. So just sort of following on from that really, and a question more to Robin, I think, really about messaging, because obviously it's, you know, I appreciate, that's the third time I've seen that presentation, so I appreciate that, and I understand that things are kind of cautiously positive in some ways, but obviously, I mean, my problem is I've just had COVID after 2 vaccinations and I didn't have mild symptoms, and the point, so I'm not being very objective about this, but it didn't surprise me as such. I never believed myself that vaccinations are a panacea, and I'm not, you know, suggesting for a moment that it isn't an incredible achievement, the vaccination program in this country, but the messaging we're getting is that it is a panacea, and actually the evidence on the ground suggests that there's loads of cases, you know, and I have been, you know, people like myself are pretty healthy, you know, don't have underlying condition. So my point is that, and obviously I'm not dead, and I haven't been in ICU, so at that level you could say, well, good for you, Alison, good that you had the vaccine, and I appreciate that, but it's still a nasty thing to have. So the point I'm making is that in the messaging, and which is good, and the stats that you're giving out there, and you're only one voice in this public conversation, is there a role for reminding people that they can still get it if they've been vaccinated, and that you know, and but without being alarmist, because we do need to rebuild some confidence, but you're not just necessarily going to get mild symptoms. Thanks.
Yes, I think that's an interpretation of mild, isn't it, as well? Because when it's described as mild symptoms, it can really mean you're not admitted to hospital, which certainly won't feel mild when you're experiencing those symptoms. And I think that's very much a challenge, isn't it, in the communication. But what we have been looking at is the evidence from our data, and we're also in communication with the NHS as well, as to whether it is possible to publish some statistics locally around. So our data locally, because the contact tracers are in conversations with the cases, one of the questions that they will ask is, have you been vaccinated? That's obviously a self-reported question. And for those people that we do manage to speak to, we will be able to get that information. But what we'd like to do is to see if we can combine it so that we get the NHS database, so that we can combine that and to see whether the cases are vaccinated or not. And as we come towards the 16th of August and the release of contacts, that's going to be even more important in our understanding which contacts are vaccinated. I certainly in any of the messages that I give have been very much giving the message that 2 vaccines dramatically reduces your risk of being admitted to hospital or of dying, but you are still at risk of contracting COVID and of passing it on as well, which is the key issue, isn't it, around contacts particularly. So I'm hopeful if we can get that data together and publish it, that it is very much it's just a factual issue, and we can see the impact that it is having on serious cases and hospital admissions. But the vaccine works in 2 ways. It works because it protects us and reduces our risk, but it also lowers the risk of us encountering COVID in the community, and those 2 things need to come together. And the vaccine can't battle its way through a wave. It needs the wave to come down in order for it to have its full effect. So were we at a fully vaccinated position last summer when our case rates were really, really low, would have been a much better starting point. And I think that's the challenge that we now have, the challenge of restarting the economy compared to managing the pandemic. And it's a really difficult path to walk. And I think it'll only be over time that we know whether we've got it right or not, won't it? But as I said, what we can do locally is keep on with that message around our figures and our cases, and we know, certainly last time we looked, it was around 1/3 of our cases had been double vaccinated.
Okay, Roy.
Thank you, Chair. couple of questions on mass gatherings, and in 2 weekends' time the football season starts, and we've opened up nightclubs. So are we working with our football clubs and our nightclubs to ensure that they are making the best use of double jabs to keep the clients within their premises and within the stadiums safe from the spread of COVID? Because this is going to be an issue that will run from now until next May.
Yeah, well, football was the super spreader last time, wasn't it? And have you had much contact with the local?
So from probably two different answers to that question. I think from the football perspective, there are regular meetings with our environmental health team who have a great deal of input and some really good conversations around how they do that safely and reviewing their risk assessments. So obviously bringing people together is a risk, and the risk sits not only within the environment of the stadium, which can be well controlled, but is also about where people are on the way in, how they travel and how they gather outside of the stadium, which is much more difficult to control. And I think that's a huge challenge. When it comes to the nightclubs, all of the businesses that are open are required to conduct health and safety risk assessments for their environments. And there is some guidance on how to do that, and the team will continue to visit and advise premises where we see that there's any incidents or outbreaks occurring in relation to those premises. I think the huge challenge is we're allowed to mix and to mingle, and those protections that we previously had are no longer in place, and so businesses can quite legitimately open and have crowds within them in close proximity, and it's really challenging to know how to manage that risk.
Okay, thank you. Councillor Lonsdale, and then I think I'm going to have to move on because of the timescale. So, Emily.
Hello. So I was wondering about what forward plans we've got for people who are suffering from long COVID and how big a problem we might have in the city.
So I may need my NHS colleagues to support me on this one. I think as far as the data is concerned, that's still emerging, and particularly not only the number but how long that long COVID may last for. But Meryl, are you able to?
Yeah, so I mean, there's a mechanism to refer into long COVID clinics. So if a patient gets identified, then we will refer in to those clinics. I think there's a lot of patients who don't present to the GP. They just assume they've got sort of symptoms of the COVID, and they don't contact us. I mean, I think with the messaging, when I speak to the youngsters, that's what I talk about if they're not vaccinated. That is not so much that I'd be worried about dying from COVID, but I'd be really worried about getting long COVID, because that would have a significant effect on them, and that seems to resonate more than the fear of dying. So, but yeah, there are a sort of mechanisms in place to refer them, but the waiting lists will get longer and longer because more and more people are getting long COVID.
And just to add to that, I think it's a good point to just remind ourselves that this isn't flu, and the narrative around we need to live with it like flu. It isn't flu, and we don't get these long-term complications with flu, and so that's part of that message, isn't it?
Okay, well, thank you. Oh, sorry, yes, come on. can I just ask people to, if they can, to remember to use the mics, particularly, well, we've got the public obviously listening, but Councillor Martin as well. So, thanks again, Robin, for that. But we best move on to item 8. No, it's item 7, and we're looking at the Poverty Commission now. I think it's James yourself that's going to present for us on the
Poverty Commission. Yeah.
Thank you.
Yeah, thank you, Chair. So I do apologise. That first slide says it's a co-presentation between Carl Tring-Willis and myself. Carl Tring-Willis couldn't make it last minute, so it's just me. So if the first half of the presentation is a little bit ropey, put that down to him, because it was a last-minute changer. But yes, just to... the reason for this presentation, the Derby Poverty Commission is newly established. It's a new commission within the city. So it's to inform you of that and to update you on where the commission is up to now. Next slide, please, would be great. I don't think we really need to know a why. Why is there a Derby Poverty Commission? Because poverty is very visible. But this is a bit of a timeline here that shows you how we've got to where we are. So there were some anti-poverty measures in the city between 2010 and 2015 that were a unified approach to anti-poverty. For reasons I won't go into, they stopped in 2015, and then it wasn't until March 2020 when COVID hit that the spotlight was really back on poverty, especially highlighted by Marcus Rashford's campaign. And that led to Councillor Yvonne Williams back in November last year approaching all of the key party leaders and cabinet to discuss restarting specifically around the child poverty agenda. She was quite buoyed by, as Councillor Webb said earlier on, about the work that the Community Hub were doing, the work that the Better Together approach was achieving, and other alliances within the city, and was looking to implement something similar around child poverty. This got agreement, but after further discussion, rather than focusing just on child poverty, we agreed that it would be better to look at a more holistic point of view. Children aren't in poverty due to their own circumstances, and so to look at the whole family approach was deemed necessary. So back in April, from that date up until April, a steering group was formed, and then in April 2021, the full membership of the Derby Poverty Commission met for the first time. Next slide, please. Thank you. If you just, there you go. So the Derby Poverty Commission is an independent commission. It dwells very much within the partnership space, which is why Peter Robinson and Paul Brookhouse, they are the chair and vice chair of the commission. Peter Robinson especially is key to this. He is, for those of you who don't know, the new Dean of Derby, so situated in the cathedral. He is key especially because he has worked on an anti-poverty commission before up in Northumberland, so has a history of great outcomes. And then Paul Brookhouse, who heads up the Derby Food for Thought Alliance, he's a vice chair. We'll move on through the rest of us. We're not especially as key. So next slide, please. So who else is on the commission? So members and advisors have been picked based on the Joseph Rowntree Foundation poverty indicators. So those 7 are listed there: income, work, low pay, education, health, housing, services, and social cohesion. So we've got this members and advisors structure. Members are those, so there's 21 of those who are experienced in a poverty indicator, who day to day are working within one of those 7 areas. They're hopefully all strategic thinkers and involved in the citywide agenda. And importantly, they're there to reflect the needs and concerns of the indicator, not just the organisation they're representing. We've asked initially for a 1-year sign-up and a strong commitment to attending every meeting. And then we've got advisors there on the right-hand side, 9 advisors. They don't necessarily have to have that day-to-day working with an indicator, but they have kind of a knowledge, skill, or access to a resource. So, for example, we've got a professor at the university. And then final point there is that we do have representatives from all of the key parties within this city, but they have been asked to join as advisors rather than members, just to help protect that independence. Next slide, please. Thank you. So where does the Derby Poverty Commission sit? As I said, it is independent, so it can decide upon itself quite where it dwells, and it chooses to dwell within that partnership space. But to keep an eye on the kind of citywide agenda and etc., and to avoid working in silo, it does feed into this governance framework there. So it feeds into the Stronger Communities Board, where all of the other alliances feed into. And then the boards from there on, I know they're subject to change in a little while, but currently then feeds into Community Recovery Board and then the Partnership Board. So next slide. So what actually is the Commission? What are we looking to do? So firstly, I'll just read these. To understand the nature of poverty and inequality of the city, to scrutinise the scope, range and impact of poverty, to communicate to stakeholders about the nature of poverty, to examine the causes of poverty and to make recommendations and proposals for alleviating poverty. Just to pick up on that final point there, and to continue a discussion that was had earlier on, making recommendations and proposals, we are looking to hold to account all of the key players within the city for anything that we recommend as a commission. That will involve things like housing standards, all that sort of stuff. We're also sitting in the community hub, so if there are ever any issues that you see common themes across the city in your GP practices, etc., and you think they fall under the poverty banner, please do get in contact with us, and we can do that lobbying as well on your behalf. Next slide, please. So we've broken up into initially a 2-year kind of framework, and this is what we're looking to do in year 1. So firstly, to develop a common understanding of poverty and the language we use to describe poverty in the city. I think importantly about that, poverty has changed, the face of poverty has changed drastically over the last 18 months. Those that are experiencing poverty are perhaps experiencing it for the first time, and so to quickly grasp and understand that is important. To quickly identify and agree the key issues in our city to form our Year 1 agenda and to make immediate inroads on them. We have hit that, and I'll explain in some next slides as to how we're doing that. To draw together our networks and develop a communication and information sharing flow, that's still a work in progress. And then last point here is to agree upon and develop a sustainable model for the Commission to be adopted from year 2. I think we've agreed upon a model, which I'll talk about in a little bit, and it's going to be quite different to how year 1 looks. Next slide, please. So the how. So for year 1, we've had 3 workshops as a full membership, and across these workshops, they were split in half. First half was to kind of create a common understanding across all members. And the second half was to kind of say, right, what do we believe the key issues are within the city? Huge kind of brainstorming exercise, and then everything that arose somewhat nicely fit within these 4 columns. So we now have 4 subgroups revolving around person, home, digital, and post-pandemic. These 4 subgroups are all led by someone on the steering commission, and they are going to be meeting between now and April regularly to look at some of the issues listed below, and to see what recommendations, etc., can be made involving these issues. That bottom line there that spans across all 4 columns, they're the issues that are apparent in every column. So, for example, coordination between services, that affects all columns. I think that's been a major issue that's been highlighted, although boards like this go some way to alleviating that, and especially cultural significances, because Derby is so diverse. Next slide, please. So for year 2, we have agreed upon looking at this poverty truth model. Poverty truth commissions were initially set up about a decade ago by a gentleman called Martin Johnston up in Scotland, and they are a model of commission that work to this phrase here, so nothing about us without us is for us. And they are centred around lived experience at its very heart. If we just tick on one more slide. So Poverty Truth Commissions, the way they work is it doesn't start the way we've started with a number of kind of key influential people across the city coming together. It starts with those of lived experience first. It gathers them into a room. So there is a method of finding 15 to 20 of people who are on the edge of society, and them coming together and sharing them stories initially amongst themselves. As they share stories, they hopefully some key themes will arise, and they are the themes that they agree upon, that they then invite 15 or so key leaders within the city to come and join them into their space and work together towards resolving. Poverty Truth Commissions are intentionally slow. They're described as cooking a Sunday dinner rather than a microwave meal. And that's because working with these lived experience individuals, there might be trust issues, there might be engagement issues. Getting them to tell their story in a way that really honours the truth is so important, and that's why slowness is a key principle. Next slide, please. So the next steps of the commission, so where are we up to? We might be slightly updated from when I wrote this presentation, but all of the subgroups, all of the focus groups have now had their initial meetings, I think apart from one group, and so they have created actions and agendas for the year. So hopefully as the year progresses, they will become more apparent in your workplaces and visible as to what they are doing. We still will be having full membership meetings. They are important. If you remember, the members are invited to represent those Joseph Rowntree indicators. If we don't have those full membership meetings, then perhaps not every indicator gets a say within all of the subgroups, so that's the importance of them. We have now launched an expanded steering group to develop the Poverty Truth Commission model to launch in April next year, hopefully launch in April next year. And then we will be producing at the end of year 1 some form of annual report which will detail any recommendations and to highlight any progress that's been made. So that is the presentation. Thank you for your time, and I'll invite any questions. Thank you.
James, thanks ever so much for that, and apologies for having to nip out for a couple of minutes there. Yeah, absolutely. We should all and have long welcomed the establishment of the commission, and I'm sure, as you've outlined, it will start to prove dividends across the city. Questions, comments, please, for James? Are there ways in which we can think, hearing what we've heard, how we can link in with the commission in respect to some of our ambitions and policies and things?
I think it's a fabulous initiative, I have to say, and I suppose it's, from what I was saying earlier, actually doing something very proactive. And the thing that struck me was actually how one man, Marcus Rashford, can put it on the map. And I know he's a footballer, but actually he's somebody without sort of lots of education, as far as I'm aware, but he just experienced and has made a difference. So quite inspiring, and actually what you're doing is inspiring. So, yeah. Great job.
It's debatable if he's a footballer. He plays for Manchester United, actually, so that's something for...
I'll just say, as this is my presentation, I'm a Man United fan, so I won't have a bad word said about Marcus Rashford.
Yes, Roy.
Yeah, Poverty Commission, as Meryl said, is welcomed, but we do need to ensure that the work that they are doing is reported back here on a regular basis, because a lot of what they are looking at relates to the health inequalities that we have across the city, and it's important that we know where these inequalities exist and we have a proactive way to try and deal with those inequalities if it is at all possible, because it won't be just local authority that is making changes to help. It will involve public health, it will involve health services to try and improve on those inequalities and reduce where possible.
Absolutely, and so I was going to raise the subject of when next to bring it back, when an appropriate point, James, if you will, to give us an update on the progress on what you've described.
I'll just say one more thing as well. The members we have on it, we do have, we've got 2 public health colleagues, and we also have Dr. Kamal Raj, who's representing both the health indicator and also the City Place Alliance. So hopefully he feeds back to there. But yeah, more than happy to come to here as well.
So I think we've got one. Oh, sorry. Councillor Longsdale for starters.
Yeah. I was just thinking, sorry, it would be really good, this thing is really good, but it would be really good to have a lot more information about how to destigmatise the classation of poverty, so that people who do need it but would say, oh, I'm not poor, I'm managing, do actually come forward to help. So that would be something that would be really useful to report back on.
Sounds like a possible work strand for the commission, for your scrutiny board, if you like, and maybe you could raise that there and work in conjunction with James and the commission to work on that, perhaps. Chris, you wanted to come in?
Yeah, thank you, and thanks for the presentation. Just to build on Roy's point, if I may, so you'd probably expect me to say something like this. So, really important as a wider determinant of health. What didn't come out in the presentation was when this slow cook finishes cooking, where exactly does it go? So, and it needs to, because it needs to be powerful and not well-meaning. And that's my challenge as we start to create the engineering of systems. There's purpose in doing that. It's not just for bureaucracy's sake. It's to enact things when they emerge. And so my question to the board really is where does this sit in the architecture of action? And where will it go formally when it pops out of the slow cooker? And what will be done with it? Thank you.
So, yeah, I take your point, and the Poverty Truth Commission bit is still a work in progress to get launched. The way they typically work is they try to be incredibly transparent and also in the public space. So when, for example, the 15 community commissioners, as they're called, get together and invite business and civic leaders to come and join them in their commission, that is typically in front of a crowd. So there's 100 to 200 people present who are aware that these people have been tasked with co-joining and creating potential resolutions, remedies, recommendations. They then get back together in a year and a half, 2 years' time, however long the Poverty Truth Commission initially takes, to present to that same crowd again of people, the public face of Derby, as to what they have achieved and how they do it. So that's how, in a non-formal way, but yeah, in terms of sitting on boards, etc., for those resolutions, that's potentially still to be worked out. Yeah.
And I would hope that any recommendations or findings from the Commission can and should come back here with for hearing and for actions. Yeah. Alison, you want to come back in?
Thank you. I am pleased to see that the Poverty Commission is up and running, and this is being looked at very systematically. And I wish you well, and I look forward to hearing further feedbacks and any action you can take. Just one, I mean, and obviously my own philosophy, because I'm now a labour and cooperative councillor, is that working with people is the key to community engagement rather than just working for them. But the only thing I know, having been a councillor who's represented one of the poorest wards in the city and now has one of the poorest areas in the city in my otherwise wealthy ward, and I'm sure you know this, but it's just for you to perhaps reflect on a little bit, is that, you know, people who are in situations of long-term poverty do not have social confidence, even if they do have the skills, which they often don't, to easily articulate their own experience, and they're very reluctant to come forward in public situations. So they do require voices, strong voices, to stand up for them sometimes. But I think in trying to engage people right on the ground is the right approach. But you do need to be careful. Obviously, I'm sure you know this, that that actually it's very difficult to get people to, and you usually end up with the same few voices, which not to discredit them at all, but they are very valuable. But there is a task to be done there in terms of if that's how you're approaching it. Thank you.
Okay. Any other further comments, questions? James, was there anything you want to say in summing up?
Just in relation to that, me and Peter did have a meeting this week because we're starting to formalise the plan of how we gather community testifying commissioners, because through other commissions it seems to be about a 6 to 9 month process, so we need to start hitting it now. We're potentially following the model of detached youth work, where you go and dwell in spaces and build relationship up there through a long, slow process of being in. Hopefully that creates trust and empathy. But for example, your fellow councillor, Paul Hazelgrave, he's brought up kind of the issue of the deaf community. There's a huge deaf community within Derby. How do we involve them? There'll be facilitation that will, for example, cost money, etc. So yeah, we're aware of it, and I take it on board. Thank you.
Okay, good. Thank you, James. I'm conscious of time still. We're getting even further behind. So we probably need to move on to item 8 and local coordination, local area coordination in Derby. Unfortunately, Neil Woodhead has been a victim of the pingdemic, but I think, Pervez, you're able to present this on his behalf.
Turn that on. Yes, absolutely. I'll pick this up. Not in the glorious array that Neil would, but I'm hoping I'll be able to give people an overview of the local area coordination operation in Derby and the findings from the evaluation report. Next slide, please. So, local area coordination is something that we've been adopted in the city for 5 or 6 years now, and it started quite small, but we always thought big about how we could roll it out right across the city and engage with other public service partners in using it as a methodology for delivery of preventative public services. So, and typically, you know, the types of people that we come across tend to be impoverished, lack of confidence, isolated, and tend to not engage with systems and services that are available to them. And it goes to the heart of what Chris talked about earlier in terms of health inequalities, what James talked about in terms of the Poverty Commission, and those people who are kind of left marginalised by society. Next slide, please, James. So what local area coordination does is it tries to empower people to be more confident and to be more resilient and to learn alongside somebody who knows the system and how things work, and try to support people to find their own solutions in the community, or using their own assets within what's known to them to support them to have a better life. And what that does as a byproduct, it prevents sucking those people into statutory services, because we know there's a lot of excess demand in statutory services, and hence we get issues with access and ability to deal with people, and we end up dealing with symptoms rather than causes because of that excess demand in the system. So local area coordination has been a gift to us, really, over the past 5 years, and we've managed to roll this out significantly across the city now, despite starting small and despite a lot of challenges along the way, challenges that continue and are not over yet. So can you move on to the next slide, please, James? So the distinguishing features of LAC is some things that I've touched on for people that they see the individual officers, the local area coordinators, as somebody who's accessible, approachable and flexible, that they're not there for them to provide a service to, but it's there as a support mechanism for them. We don't have referrals, there's no eligibility criteria, there's an opportunity for a conversation and to take forward the result of that conversation. So, and the relationship lasts with the local area coordinator for as long as necessary. And we work at 2 levels, one with individuals, but 2 with communities, in terms of building social capital and supporting like-minded individuals to build that social capital within communities, so communities become more resilient within themselves, rather than depending upon statutory services. And this all started out from a very selfish perspective, really, was about managing demand for adult social care services in the city, because we were seeing excess referrals that we couldn't respond to in a timely way, and gaps started to appear in terms of the numbers of people that we could help and support realistically with the resources we had, and we developed this methodology of working and then spread it out across the city. So next slide, please. So we've undertaken quite a bit of both qualitative and quantitative analysis using theory of change and different methodologies, independent evaluations, and we know this works, and we are producing some sustainable change and outcomes for people in the city. Wherever we've introduced this methodology as a way of working, it really has benefited. And in the overarching report that you've got with your papers, at paragraphs 4.5, let me just check that. So, sorry, 4.4 are some of the quantifiable benefits that we've experienced through the use of local area coordination in the city, right across the system in terms of both social care and health presentations. At a time when we know that all of our public service systems are under a huge amount of pressure to see people and to find solutions to presenting problems, this has delivered significant benefits for our communities. And we continue at 4.5, we detail some of the opportunities that exist for us now and into the future. But what I would say is that we'd like to recommend local area coordination to our partner organisations, and we'd like to see further join up for across health and local authorities in terms of social prescribing, joining up with local area coordination and joining up with our community hub that we've got off the ground, which came about as a result of the pandemic. So pooling our resources in that preventative offer so that we work in a similar way across our organisations, and we maximise the benefit that we can leverage out of this asset-based approach for the city moving forward, because there's still lots of join up that we can do in these areas, because prevention is going to be a big stream, I believe, in tackling our health inequalities and getting to people early on in their presentation, so we don't wait until crisis or people need emergency intervention, because the outcomes from there are never that positive for the individual. If we can get to people much further upstream, the better chance and the less resource we're likely to expend in correcting that situation and supporting that individual to correct it for themselves, really. So you want to move on to the next slide? So I'd commend the report to people. There was a detailed evaluation exec summary that was circulated. Please do have a read of that. There are some human stories in that you'll be able to relate to, of people who've been through the local area coordination journey and come out on the other side, and who are now champions and advocate for this approach in the city. I'm an evangelist for this approach. I think we should all be, because the benefits are quantifiable for a small amount of investment, actually, relative to the overall scale of the health and social care investment across our footprint. It is something that we need to build on and grow, and we'd advocate it, and we'd appreciate your buy-in now and in the future, particularly in terms of as an approach for place-based interventions in the city, because place is going to be a big part of the health and social care landscape moving forward, with ICPs in the ICS, and this methodology really needs to play or loom large within some of our delivery vehicles if we're going to cope with the demand and the scale of demand that we're going to have in the system. And I'd just stop there, really, Chris.
Thank you, Pervez. Absolutely with you, agree with you on all this. We started small, we've developed the resource across the city, but I see it as a system that has great potential to go on and do better, even greater things. I was out on a walkabout in my own ward on Monday and the local area coordinator came with us, and he saw 2 of his clients out there on the street, both of whom were known to me anyway, because of the extent of the need. They were some of my best customers, if you like, but to be able to reduce the numbers of calls for service from the GP and from the hospital and emergency calls vastly, greatly reduced, because they've been able to provide something of the intensity of support that's needed by some of these clients. So yeah, absolutely, we should build on what we've got so far, and thank you for that report. Any quick questions or comments in relation to this? Yes?
Certainly, practically, we found it really beneficial, and just, yeah, they've helped patients enormously. We've got social prescribers in the surgery, we've got care coordinators that link to the surgery, so I agree they all need to be linked up. I suppose the hesitation from primary care, because it comes through the primary care network, the social prescribers, is if it all becomes joined up, whether actually council funding will reduce. So whether that can be assured if the system all combines together. But yeah, fabulous resource, and they're making massive differences to the patients' lives on an individual basis. I think COVID hasn't helped, because a lot of the resources they would use, a lot of their groups they would direct patients to, have not been up and running. But yeah, fabulous service.
Yeah, they certainly had some restrictions on the amount of actual one-to-one contact that they've been able to give over recent weeks and months, but we should be coming out the other side of that and should be able to build on it. So yes, Dina.
It truly is inspiring to see some of the outcomes on a practical front. If I'm engaging with people in our hospitals, I talk about these stories. I know you described this isn't a referral-based team or service, but still, it might be something that people, if aware, could signal to people we come into contact with. What's your message on how we steer people to this support if people are not aware that we think it might be of value to them?
I'd say just do it. Just do it. And, all the local area coordinators that we've got are assigned to certain geographies, and wherever the patient or the person that you think that they can support lives, then that local area coordinator will make an initial contact with that individual, and you can contact the local area coordinator. All the local area coordinators and their contact details are available on the City Council website.
Okay, yes.
Hi, thank you, Chair. I think it's a fantastic initiative. It really is a fantastic initiative. However, I think there needs to be a lot better understanding of how the local area coordinators work with existing structures, with the neighbourhood managers, neighbourhood officers, good neighbourhood officers, local councillors. I just think that there needs to be some work done around how it fits in and how everybody works together to the most effective way, really.
Yeah, I'm sure that could be better, but the way we do it is through the neighbourhood board and through our neighbourhood officer, and involving them in the relevant events and ongoing activities throughout the ward, and it naturally brings them in and actually results in them recognising some clients that need their services too. So yeah, it probably part of the agenda of the working better together agenda that's coming. So yeah, take your point on that, Daniel.
Yeah, I think what I mean about that more, there's a lot of crossover. There is a lot of crossover in workings. So I think it needs to be very clearly defined of what the role consists of, and how that fits into existing structures, if you know what I mean.
And that's maybe for the local area coordinators themselves to identify where their role best fits.
Absolutely. Thank you.
Right, I'll take you, and then I'm going to have to move on because Steve's been sat very patiently waiting to give us some input.
I'll be quick then, Chair. The theory behind local area coordination is to work with people, not for people, so that those people who are supported end up resilient and being able to look after themselves. It fits in with the neighbourhood agenda, but only if the local area coordinator is allowed to deal with those individuals in that way. If it's dealt with by somebody else and it's done for them, then it doesn't work and it doesn't keep the sustainability of that person who's being supported. So local area coordinators need to be treated as part of the offer, but working with the individual, not for the individual.
And that's why I see it as important that the engagement period with the client is not time limited, because it's the individual needs need to be dealt with until they're sorted. Okay, good. Thank you. Steve, we've squeezed you a little bit on time, but by all means, if you'd like to tell us a little about your report, which is gratefully received.
Well, I don't actually, in the time we've got, want to talk too much about the report because it's fairly self-explanatory, but just to say that there is a phase 2 going on at the moment, and that it has has been far more effective because we've modified the way we do things, and we've also, with help of Joined Up Care Derbyshire, been able to get placards up at the arena. And we've had a lot more uptake with information since then. As the groups have become younger going through the arena, they've used Facebook and such like in a lot, social media in a lot more effectively, such that we've now got roughly 700 comments a month coming through, which is quite substantial, and this information is being relayed to Joined Up Care, and I hope it's more relevant now than it was initially, and I'll leave it there.
Sorry, thanks, Steve. No, it's good to get up-to-date comments as well, isn't it, and to be able to have the opportunity to react to them. So again, thanks for your report and thanks for your efforts as you're going along with this. Robin, that leaves us about 3 minutes to deal with the with the potential for how we're going to review the Health and Wellbeing Board input. Can I suggest we might, because it's a while till the next board, which is October, I think, that we're scheduled. Can we do it by remote electronically? Get some input from, if you would just want to set a scene for someone
to start the conversation electronically.
Start the conversation.
Yeah, I think that would be a really good idea. Yeah, Alison's done a brief paper in the pack, but it just links on to the earlier conversations with Chris around the changes within the system and the ICS development, plus the fact that we haven't reviewed our terms of reference or the membership of the board over the couple of years, just because of because of the situation with COVID over the past year. We haven't done that. So yeah, it was just to take the next board as an opportunity to have more of a development session and consider the role of the board within the context of the system changes, but also to consider the membership of the board so that we've got that absolutely right as well. But yes, we can absolutely start that off via email before that meeting.
Absolutely. Maybe you and I in one of our meetings could address those specifics around the terms of reference and the membership and come out with some recommendations or sort of proposals for discussion. Is that okay? So we've reached the end of our allotted time. Thank you for coming. As usual, it gets away from us because there's a lot to discuss, but it's nice for me to see faces again and have some human contact. Hopefully we've done that in as safe a way as we possibly can. Keep up the good work. Everybody stay safe, and we'll see you all again in October, hopefully.